Thank you very much. I really like the idea of this panel, what we've learned and where we're headed, because that conversation brings meaning to this 50-year anniversary. This is the perfect time to take stock of the incredibly important programs and really think about the future. Medicare and Medicaid have shown for many years that our country can deliver on the promise of affordable health care, which is really a basic need for everyone. But we know these programs face challenges, especially as the boomer generation gets older. We need them to stay financially sound, but Americans also are counting on Medicare and Medicaid to continue fulfilling this vital mission. So it's essential that we discuss responsible ways to keep these programs strong and effective, ways that don't harm individuals who need that health care. This panel is a reminder that Medicare and Medicaid have benefited from leaderships on both sides of the aisle. They've grown and evolved with bipartisan support. AARP believes that an inclusive policy debate, one that recognizes how important these programs are to families all over this country, will lead to the best possible future for Medicaid and Medicare. So I'm really looking forward to this discussion and hearing what our distinguished panelists have to say. We're very fortunate to have our moderator, Jackie Judd. You probably know Jackie from her award-winning career in broadcast journalism. For many years, she was a star at ABC Television News, where she reported for World News Tonight, Nightline, Primetime Live, and Good Morning America. But you may not know Jackie also specialized in health care. After her television career, she moved on to the Kaiser Family Foundation, where she served as vice president and executive producer of multimedia. So I'm delighted to turn over the program to Jackie and leave this conversation in her capable hands. Thank you.
Good morning, everyone. I'm delighted to be a part of this rich conversation and to be joined in that conversation with Nancy Ann DeParle and Gail Wilensky. And I'm going to make the bold prediction that everybody in this room knows their histories. And it's also published in your brochure, so I'm not going to go into great detail, but they were both, of course, administrators at CMS and beyond. I'm going to contribute a little bit of history to the first panel that got us going. When I was at the Kaiser Family Foundation, we decided to produce a documentary to mark the 40th anniversary of Medicare and Medicaid. And I had the great treat and privilege of interviewing the AMA president who Mrs. Raab referred to, and his name was Dr. Edward Annis. I interviewed him in 2004. He was 90 or 91 at that point. He was spry and dynamic and was every bit as convinced in 2004 as he was 40 years earlier that Medicare was going to create what he called a socialist yoke around doctors' necks across America. And he was very passionate about it. He is now deceased, but it was a treat to see him. And I bring this up to make the point that passions run high about these programs, even today, 50 years later. Part of the political passions that we've seen played out on a fairly annual basis is the doc fix. From a background in journalism, I can't ignore the headline of the day. Yesterday, the Senate passed a doc fix. It appears headed for the White House. And this annual silly exercise we all go through may be finished. So I would like to turn to both of you to ask for just a quick analysis of what you think of this legislation that was passed.
I think it's a terrific accomplishment, and I was sitting here reflecting on the role of the AMA and the passage of Medicare and Medicaid with respect to the so-called doc fix, the reform of the way Medicare pays physicians. The AMA and its leadership was instrumental in working for the past decade on this reform package. And I think it's very good, and I think will help to strengthen Medicare and will have spillover effects in all the other healthcare programs in a positive way, moving towards paying physicians for the value they add to the healthcare system.
Gail?
I have a particularly pleasurable response to the passage of this legislation because I was the administrator on hand when the relative value scale was first implemented and also saw the 25th anniversary celebration of Medicare and Medicaid. It seemed at the time a better strategy than what had been used previously in terms of using what was out in the insurance world, the usual and customary fee schedule. In fact, what we have seen over time is that focusing on very small units of service to bill, which is inherent in the relative value scale, with a spending limit laid on top of it, both pushed physicians in unhelpful directions, not being rewarded or encouraged, or sometimes even easily allowed to focus on the best clinical outcomes and the most efficiency, and engaged in the worst form of collective guilt. Because if spending grew too fast, all fees for physicians for all services were uniformly reduced. It was just inherently unfair. Most of the time, of course, the Congress would intervene just before the reduction was to take effect and stop it. But the uncertainty caused so much frustration that the AMA was focusing way too much time on the SGR fix, as a policy person I say that, and not being able to focus on the bigger issues. Unlike the AMA when Medicare was passed, I actually found the AMA very helpful in explaining and doing outreach for the relative value scale when it was introduced. I'm sure this will be a much happier time for them to have finally moved away from the spending limit of the SGR. But many more things to come now that we've gotten this far.
And I think it's always important to kind of bring it back to the beneficiary side. What impact will this doc fix have on beneficiaries? Is there some cost shifting involved?
No, I think what impact it will have is beneficiaries will know they have a stable system now for payment of physicians, and it will encourage physicians to look more broadly at their care and at providing preventive care and the things they need, as opposed to worrying every year about whether their pay is going to get cut depending on how the nation's GDP performs. And I think it should also give them and give all of us real encouragement that on a bipartisan basis, pretty overwhelmingly, Congress was able to get together on this issue and find common ground. And I think that's been an important part of the history of Medicare over the years. As Gail said, different things have been tried. It's been an incredible laboratory for trying to advance health policy. Different things are tried. Sometimes they work, sometimes they don't. Congress and the administration have been able to get together and work on the next iteration, the next solution. And this is an example of that.
Well, other than not having to hear physicians be distressed about the potential reduction of 21% in their fees, which of course I think they knew wasn't going to happen, beneficiaries shouldn't be very directly affected. As best we can tell, healthcare professionals, especially physicians, have tried very hard to do the right thing for their patients all along. But we had a payment system that made it really hard. You had physicians billing for very small units of service. We had a lot of talk about how we wanted to increase value and improve clinical outcomes and encourage efficiency. And then we had a payment system that really pushed you in the opposite direction. Fortunately, most of our professionals ignored those incentives inherent in the fee schedule with the spending limit and did as best they could the right thing. I'm sure Nancy Ann heard this. I would hear so often, both running Medicare and then I chaired the Medicare Payment Advisory Commission for its first 4 years, of having physicians say, you guys make it so hard for us to take care of patients the way we'd like to, of trying to spend some time talking to them if they have diabetes or other chronic diseases, and not feeling like we're pushed financially to do things as opposed to just take care and get the best health outcomes. So there are a lot of issues that we're going to still have to resolve. Updates are going to come up of how much more physicians should be paid and what counts for bonuses and what counts for penalties. So there's a lot of work. Nancy Ann and I are going to be busy for many years to come, and you moderating such discussions.
Well, let's step back from the day's headlines and take a slightly longer view. The pace of change in both of these programs has so accelerated over the past decade, Nancy and Ann, in part under your watch. New models of care, new payment schemes. And I'm wondering, I would ask each of you, what in these pioneering models do you see that have legs for the next 10 or 20 years to fundamentally address some of the critical issues we're facing?
Well, I would start, I can't help sitting here as we're celebrating Medicare's 50th anniversary, thinking about sitting with my grandmother, who was one of the first beneficiaries and who was 67 when Medicare was passed. And sitting at her kitchen table in Rockwood, Tennessee, she had a little box of her bills on the table. And she was talking about whether Medicare would help her. And I think it definitely has. So I think as we look toward the future, it's really important to remember the stories. For me, it's my grandmother. For the other people here, it's someone else in their family. It's important to remember those stories. And as we look at the future and where the program's going, to always hold fast to the best of what Medicare has done, which is to provide a stable, affordable system of health insurance for seniors. And my grandmother lived to be 98. And I'm convinced that one reason why she did is because she didn't have to worry about her health care costs. Mm-hmm. And of course, it also afforded her family members the ability not to have to worry. So that's huge. Whatever we do, we need to keep that in mind. And I think we will. Gail alluded to the new programs that are being developed now and are being implemented around the country to try to move towards more team-based care, right, towards what is called population health, caring for a group of patients, trying to help them get better, showing outcomes as opposed to just the fee-for-service a la carte payment system that we've had in the past. Medicare Advantage plans are growing in part because that is part of what they can offer at their best to Medicare beneficiaries. So I think those are models that show a lot of promise. And the great news is that not only are hospitals and physicians and other healthcare providers not opposed to them, they're embracing them, they're working to take them to the next level. Private sector insurers are doing the same thing. So I think we're all rowing in the same direction here.
Well, let me try to explain a little bit about what the new model's being tried, and then what I think we know and don't know. There's an effort with CMS, Centers for Medicare and Medicaid Services, trying to encourage groups to come in and put bundles of payments together. Mainly, that is, hospitals with physicians, hospitals with post-acute care, home care, or skilled nursing facilities, sometimes all of the above together, and to see whether or not this improves value, that is the clinical outcome to the patient, improves patient satisfaction, and also reduces costs. There are these accountable care organizations, which are kind of a baby step toward a more integrated delivery system, getting physicians and hospitals that haven't worked together to agree to combine services and efforts, and if they can show some savings and meet quality metrics, very important, then they get to share the savings with Medicare. One of the problems we need to recognize is that the pilot projects that we're trying, very good idea, try it before you roll it out to all 44, 46 million seniors, are voluntary. That means there's a big self-selection bias. The groups that come in to try it may be the most innovative, the most entrepreneurial, the most organized, and what
the
they
least
find,
frail.
Pardon?
And probably the least frail.
Yeah, and
right?
well, whether their populations are more or less frail can be measured. There are risk adjustments. You know, they're okay. They're not bad, but they're not perfect. The question is, if we were to adopt this for the country, for all people, all providers on Medicare, would the results be the same? The answer is it's hard to tell unless you try to expand the successful ones and see whether they can be scaled up. One of the big surprises I've found as a former researcher, mostly policy person, is that what works in the small doesn't always work in the big in this country. So you might have a pilot project work really well in a few areas of one state. But when you try to replicate it and see what happens if you try it in 8 states, sometimes it just doesn't work the same. And it may be the self-selection, it may be that trying it on a lot of places just introduces problems you didn't anticipate. So we're gonna have to make sure that what looks like it has legs, so to speak, it's producing better clinical outcomes at lower costs, can be scaled and replicated. And we're gonna have to really drive that. I'm a little jaundiced about whether we're gonna find things that work and then nothing happens to that. Maybe because I lived through what was a very successful project of paying a single amount for heart valve replacement and bypass surgery. I worked really hard to get this pilot off the ground, much harder than I thought I would have to. As administrator, I would say, let's get this done, and it would happen. Well, 18 months later, it actually happened, and I was yelling and screaming all the way there. And then actually by the time Nancy Ann's term had finished, she was very supportive. She expanded it, continued it, and then it just kind of died away. We're gonna have to really drive these changes because while we're seeing a slowdown now, I'm sure we'll talk about it, it's not clear what's causing the slowdown, whether it'll continue. And with all the baby boomers coming on, there's going to be a financing challenge, even in the highly unlikely event we saw the slowdown continue into the future. So we're really going to have to take advantage of some of these, we think, initial successes. It's kind of too early to know if they're really successful.
The title,
positive, I think, than Gail is about that. In part because she's right that back in the day, I was there for the 35th anniversary of Medicare and Medicaid, and you were there for the 25th, it sounds like. So back in our day, when you did a demonstration program, it was just that. It was small, it was very contained usually. These demonstrations that have been authorized now for Medicare are very wide scale. As many as, you know, a huge percentage, 10% or more of the Medicare beneficiaries have access to one of these accountable care organizations. So we're going to know sooner rather than later whether they work. But secondly, if they do work, if they are able to control costs and also increase quality, then the Secretary has the ability to roll them out nationwide. That is not something that the Secretary had when you and I were running Medicare. And I think that was built into the law because Congress realized that if we really want to see if some of these things work and encourage the private sector to change, because why would you have an incentive to enter into one of these demonstrations if you thought it'll be like the one that I did before and it'll be a few years and then I'll have to put everything back where it was. So I think it sends a signal to the private sector as well. And
well, the ACOs are a good model in the sense that a lot of ACOs are really struggling. I am, as I've said, I think it is a fine way to see if we can get people who haven't been working together to work together. A lot of the very experienced, the so-called pioneer ACOs that were willing to take risk of loss and gain, a number of them have dropped out, and some of the ones that are in the gentler version of the ACO are struggling. Again, this is not a criticism. They're trying something new. If you don't have failures, you aren't trying the right thing. Some people can't do it. And driving this change will be important.
Part of the title of our panel is Lessons Learned. So I'd ask you, Nancy Ann, building on what Gail said about her frustration of seeing success and then seeing it kind of tail off. What lesson did you learn when you were in government about how when you see success, you make it stick and grow and go to the next phase in a system as complex as this?
So one example is this very one. I too had the experience of a number of demonstrations that were quite small, very geographically contained, that were successful. And then they would die. And I think, an experience that I had taught me that, and I think President Johnson could have told me this probably, that to make this successful, it needs to be in more than one person's congressional district. You need to have not just the senator from Virginia, but the senator from Texas and the senator from Idaho invested in looking at the success, seeing why it is helping Medicare, and helping us strategize about how to expand it. So that's one thing that I learned.
We can't have a conversation about Medicare without talking about the baby boomers. You just alluded to it, Gail. I think I heard last night that enrollment in 2030 will be double from what it was in the year 2000. Those are mind-boggling statistics. How does the system absorb all of us? And what are the financial signposts that we need to look for that this can be paid for and contained?
Well, it will be an interesting trajectory. I didn't know the answer to this. Somebody asked me the question, so now I went and looked. It's not a linear increase. It is a doubling. We're going to go to about 78 million or so on Medicare by the time we get to 2030. It's in two bulges. We're in the middle of the first bulge. Not hard to imagine when you think back. These are the people who were born between 46 and 49. All those fellows at that time came back from World War II, had time to say, hi, honey, and started having babies. Then there is kind of a leveling off. And then there is another bulge that occurred in the late 50s, early 60s. I'm not quite sure about that one. But it means that we are going to feel the financial effects of this rush. 10,000 people sign up a day starting in January 2011. I think that's the phrase I've heard. It will put pressure on how services are provided. I just spent almost the last 2 years on a graduate medical education committee for the Institute of Medicine, and a lot of concern about, will we have the right mix of physicians? Will we have the right mix of physicians and nurse practitioners and other nurses, and can we get them to practice in teams and be ready to take care of chronic care? So we will both have challenges in terms of who's coming into Medicare and the numbers. The financial challenge is going to be a lot on the general revenue side, because almost half of Medicare spending now comes out of general revenue. We tend to think about it as the wage tax that finances hospital care and some of the nursing home care, but it's actually almost as much coming out of general revenues. My guess is sometime around the end of this decade, maybe 2018, we will see an awful lot more financial pressure coming on board as this first wave is. The good news is they seem to be healthier people coming in, and we have to be a little careful not to project the experience of 2 or 3 decades ago of people who were 65 to 70, how healthy they were, what kind of health care services they used, because many of the people who are aging in now are healthier than their predecessors. Good thing, because they appear to be likely to be around us for a long time. The other end, we're going to have a lot more of what are not very kindly called the old, people who are above 85. Maybe it'll start to be termed above 90. And so it will be both financing, but the actual provision of care and figuring out how to take care of a chronic care population with a healthcare system that's still very much focused on acute care.
Well, and Gail mentioned the year 2030 is when the big influx of people, when Medicare will have doubled. That's an interesting year because it's also the year that the trustees say that the trust fund would become exhausted. But the good news there is, look how far out that is. And why is it that far out? It's because of the way Medicare's spending has been slowed over the past 3 or 4 years. We're now, I think I saw that for 2014, the per capita beneficiary spending increase was 0%. It's at historic lows. Now, as an economist, Gail, you're right to question, can this continue, and wonder if it will, but I see some very positive signs that there have been some structural changes in the way that providers are operating. Too early to tell if they'll continue, but the physician payment reform, I think, lends further optimism to my belief that they will be able to change the way that they're doing business in such a way that it helps to slow spending growth, even as new people become eligible. And of course, we'll also be bringing in more people who have had coverage throughout their lifetimes. And I think we have reason to believe that can make a difference in the healthiness of the people who are becoming eligible for Medicare, which should also have an impact. If they've been getting preventive care their entire lives, if they've been getting access to the kind of care they need to prevent hospitalizations, that will make a difference. We've also made huge strides in quality that Medicare, of the benefit that Medicare is providing. We've, in the past few years, reduced readmissions rates by 10%, reduced hospital-acquired conditions by, I think, 17%. So all of those things make me optimistic that we'll be able to work together to figure out what the next changes are we need to make to accommodate the bolus of seniors who will be joining Medicare.
Let's talk for a few minutes about Medicaid. In this video I talked about before that I did for the Kaiser Family Foundation, it's been updated to reflect the changes of the past decade. It's available online if any of you want to see it or use it as at conferences or in classrooms. But in the updated documentary, Bruce Vladeck, who was also head of HCFA for a period of time, makes the point about Medicaid that for many years it was seen Medicaid was synonymous with welfare. The words were almost interchangeable, and that linkage has really been broken in recent years. So I would first like one of you to take that issue on and give us the long view of how Medicaid has transformed itself quite radically.
Well, Bruce was the head between the two of us. If you think back about how Medicare was set up, it was explicitly tied to the receipt of welfare. So Medicaid. It's not an accident that people thought about Medicaid and welfare as being synonymous. It was the major reason you had Medicaid. When I was around, I'm sure when Nancy Ann was around also, people would complain to me about all of the people who were low income, sometimes poor, very poor even, depending on their state, and where the income cutoff was or the asset cutoff was, as to why Medicaid was such a bad program like that. And my response was that it's not fair to criticize Medicaid for being something nobody structured it to be, which was a general program to support people because they were low income. And that began to change most noticeably in the late 1980s. Very active work by Henry Waxman, who was head of the Health Subcommittee of Energy and Commerce, a passionate supporter of Medicaid, who used in what was regarded as not a very friendly, hospitable period, all the strategies he could think of to break some of these linkages, initially by having women who became pregnant become eligible for Medicaid up to a very high income level, having all children who were under 100% of the poverty line become eligible for Medicaid coverage. It's that gradual change with a big push during the time that Nancy Ann was there with what is called the TANF program, the welfare reform program that President Clinton signed into law in 1996, was a further change between the receipt of welfare and the eligibility. But it is obviously the Affordable Care Act, which expanded Medicaid coverage up to those who are 138% of the poverty line, irrespective of other characteristics to be eligible for a program like Medicaid that really most has transformed this to the program that is now on the books for people because they are low income. I would have personally preferred that as a Senate bill at one point allowed, that people above the poverty line have a choice about whether to be on the exchange or in Medicaid, be able to take their money. But the fact that we now as a country allow for coverage if the state buys in, that's really the final decoupling of Medicaid and welfare receipt as I see it.
Right, and the other thing that happened, and I was reminded of this last week, I was talking to a student who was writing his dissertation about Medicaid. He was writing about 1115 waivers, which the people in this room know what they are, but just to explain, it's a provision of the law that allowed for states to do experimentation in consultation with and with approval of the HHS, the agency running Medicaid. And that provision was around since it was the beginning of the law. It was in there in 1965, but it really wasn't used until the 1990s when Bruce Vladeck was administrator and later when I followed. And it allowed states to do quite a bit of experimentation, which they used to build on some of these changes
early 90s as
and expand their coverage. And it led to things like TennCare, where Medicaid dollars were used in Tennessee to cover more uninsured people, a population that had not been eligible for Medicaid. It led to things like the Massachusetts connector and that healthcare reform, and you can draw a straight line between that and the Affordable Care Act. So the state experimentation, the states as laboratories of healthcare really was enabled by the Medicaid program, and that is part of what led us to where we are today with a much broader program that is really an indelible part of the fabric of our great society.
What are the implications of, I think Secretary Sebelius may have referred to it as a two-tiered system, with some states expanding Medicaid under the ACA and about 20 or 22 other states choosing not to. What are the implications of having a system like that in place, especially for the recipients?
Well, we had something like that with the beginning of Medicaid, in that it's always been a voluntary program. The states can decide whether or not they could decide whether or not to adopt Medicaid because they had a financial stake in it. And it took, 10, 15 years for all states to finally decide they would have a Medicaid program. Even with the state children's health insurance program that I helped to implement, it was passed while I was there. That took, a handful of years for every state to finally decide they would adopt and have a children's health insurance program. So some of this is just what happens with these new programs. It's part of the passions around the issue around healthcare that you talked about, Jackie. But look, it makes a huge difference. I'm not going to be able to cite all the studies, but we're already seeing evidence that it makes a difference if you live in a state that has expanded Medicaid and you're getting early lab tests to determine whether you have diabetes or not. That makes a difference in your life. It makes a difference for hospitals in terms of their uncompensated care. So, and that's why I'm confident that over time, all the states are going to have an expanded Medicaid program.
Well, I was just going to say, it sounds like that's what you believe, that over a period of time, all the states
I do believe
will sign on to this.
I think history supports
in a decade, in 10 years?
I don't think it'll take 10 years.
Okay. We are clearly seeing more states that are signing on. I thought as angry as governors and Republicans were after the Affordable Care Act, and I think it's almost impossible to understate the level of anger. I have been in a few meetings where it has bubbled over, and I was somewhat taken aback. That I assumed there was so much money on the table they would take it, but I was wrong. And 2014 came and went, and a large number have not. But you are seeing in their own way a number of the red states if their legislature as well as their governor is willing to find ways that are acceptable. And I agree with Nancy Ann that I think you will see this continue, and it will depend a lot on what happens in 2016, after which I would assume most people that look out will say there are some significant modifications that are going to happen to the Affordable Care Act, not necessarily bad modifications, but modifications, or they're not, depending on what the election produces, and maybe then settle down and looking at things as they are. But not having expanded coverage is a problem. It's a problem for the people who are uninsured. It's a problem for the communities where they live, for the physicians and hospitals that ultimately provide them for services, because among other things, Medicare says to a hospital, turn someone away and they're not medically stable and we will get you. Medicare doesn't enforce all of its rules, but the so-called EMTALA rules, which is what this is under, that's one of the ones they vigorously enforce. And trying to get coverage, and we can debate how much coverage and where you should buy it, and who should fund it, but that coverage is really important. And I think that is becoming more accepted with a lot of debate about how either it should be or should have been, but at some point will be, it is now the law, it is clearly the law of the land, and people are going to move on.
And you asked what we learned from the original Medicare and Medicaid. So one thing was the flexibility that was built into Medicaid to allow state experimentation. And you're seeing that happen now with a number of the Republican governors who are choosing to try to work with the administration to expand coverage and asking if they can do things slightly differently, whether it's, and Democrats too, whether it's offering private plans or some variation in co-pays and that kind of thing. And I think that's healthy, and that will continue.
And I will give the administration credit of being more flexible in some of the requests that have come their way than I had thought might be the case, and is trying to encourage interest. Sometimes Republican governors take the rap. People ought to look. It's actually, in some cases, the governors would like to make the expansion, but the legislatures are adamantly opposed. The fact they will be responsible for 10%, if it's 10% of a big expansion, that's not an irrelevant issue. The question will be, can you find a way to expand coverage as much and to as many people as possible?
I want to open it up to the audience right after this question. You mentioned 2016. We are entering an election season. What are your expectations about whether parts of Medicaid, parts of Medicare will become part of the political discourse of the next year?
Of course, they always have been. One of the guarantees that anybody who's been involved in running Medicare and Medicaid has is that when an election comes up, this will be an issue. It has been as long as I can remember. It's hard to really accept that we are already into the 2016 election cycle quite as much as we are. There's no question that Medicaid, the Affordable Care Act, the state of the healthcare system in the U.S. Will be an issue, whether it's as much an issue in the primaries as it becomes in the final election, the regular election or not. That depends on the parties as to whether or not it's really what's motivating their candidates and their
how
supporters.
the Supreme Court rules.
Well, that's no small issue about what happens. There is going to be a scramble in Washington if the Supreme Court supports the defendants, the plaintiffs, and if not, there will still be a lot of response, but it'll be of a somewhat different nature.
I guess I disagree a little bit. I think health care is always an issue in an election. It's just something that people care about, and it will be an issue. I don't think that the candidates will want to spend a lot of their time talking about Medicare. I just don't. I think that,
Why?
except to say they support it. Well, look, you have a program that has, I don't know what the approval ratings are, but they've got to be 2 or 3 times
Pretty high.
any politician I've seen
Yeah.
recently. It's a very popular program.
That's a low bar.
Perhaps. It's a very popular program.
According to the survey.
It's a very popular program, and it should be. People have stable, affordable, for the most part, coverage. Their providers are changing in ways that I think are helping to bring down the rate of cost growth. The program's solvent until 2030. There's no house on fire here. We need to work together on a bipartisan basis to make sure that we're improving and strengthening Medicare for the future, and I believe we will. Medicaid could be an issue, and I agree with Gail, the Affordable Care Act seems to be always the issue du jour, so I don't see that changing, but I don't think Medicare, except to say I'm for it.
Any questions? Very quiet audience. You all need some lunch, I think. No? Okay, then let me wrap up and ask you each a final question. The previous panel speculated about what folks would be sitting on this stage talking about 50 years from now. I think that's too far out. Let's talk about 10 years from now. What do you think will be said about these 2 historic programs?
10 years from now, we will know a huge amount now about this tumultuous period in healthcare that we have just gone through. Mm-hmm. I think actually in 2018, we'll know a lot that we don't know now in terms of how much of the slowdown that we have been seeing, which has been very important for Medicare, as well as healthcare in general, is a drag from this very long, very deep recession, or some early successes from some of the changes being tried, but not necessarily either sustainable or sustained. By 2018, I think we're likely to have seen 3 or 4 years of a robust economic recovery, and then we'll have a much better idea about whether there's some real change going on. The second thing that we're going to know by the end of the decade is whether or not most of the savings in Medicare, which are not because Medicare costs less, but because Medicare is being reimbursed at lower rates as a result of the Affordable Care Act, it was built into the legislation. Having someone get paid less does not mean it costs less. The hope is it will drive hospitals and physicians to figure out how to do it for less money with some of the pilots or whatever, but we don't know that. And it's why the actuary in 2010 said he's not sure that these reductions that are legislated in the law are going to be able to play themselves out because they will begin to have too many access pressures for seniors, which Congress will not tolerate. Hasn't, won't in the future either. So by the time we get 10 years out, we'll have had a lot of baby boomers retiring. They will be very impatient, demanding, as they always have been, as they've gone through every phase of their life, putting a lot of pressure on Medicare. We'll have a much better idea about whether we really have figured out how to slow down in a sustainable way the rate of healthcare spending. Most people forget we spent the whole decade of the 90s. That's 10 years. That's like a lot longer than since 2008 or 2010 yet, with healthcare spending at about 13% of the GDP. Very slow spending and a robust economy. And after that decade, it all went away. And that was because the kinds of changes that had driven that were not sustainable. Now, we're trying different things, and I'm hopeful that at least some of them will be. Maybe because I'm older and been around longer, I'm more agnostic and just want to monitor. I will mention the reason we had the uptick in Medicare rates, Medicare Advantage rates announced a week or two ago was because of Medicare. The actuary said spending is going up just a little. Yeah. Not a big issue. It's just a reminder, we don't know yet what's happening. So I think a decade out, we'll have a much better idea. And I assume that people will have gotten over the Affordable Care Act one way or another. Either we will have modified it, or they will just accept it as a fact of life.
No more repeal votes.
Yes, no more repeal votes. Exactly, I'll be for that. So I think Gail is right that the economic and fiscal issues will still be with us, and so whoever's sitting on this stage in 10 years or in 50 years will be talking about those. And also about quality and how do we make sure that our Medicare beneficiaries and our Medicaid, the working families who are receiving Medicaid are getting good quality care. All those issues will still be here. I can't give you the specifics of them, but I'll guarantee you one thing. We will still all be celebrating the creation of Medicare and Medicaid and the brilliance and the compassion that led President Johnson and our other leaders at that time to bring these two programs to be part of the fabric of our society.
An appropriate final word. Thank you both so very much. Really appreciate it.